schizophrenia is a very elusive concept. Still, we don't know what schizophrenia is. Each one of us are describing schizophrenia as something like a blind man in Hindustan. We don't have a precise know in detail about what is schizophrenia. Now we have given up the subtyping of schizophrenia, and now we have dimensions of schizophrenia. Now, pharmacology of schizophrenia has now reached a stage where we are trying to give drugs for cognition, drugs for A motivation, drugs for negative symptoms, and drugs for positive schizophrenia symptoms. So, we learned there are more than 50 drugs, mainly under trial, just to improve the cognition in schizophrenia. With all these drugs, still we have cane-resistant schizophrenia, super cane-resistant schizophrenia. Still we don't know any number of patients who don't respond to drugs. Now, in this context, any precision medicine and drugs and side effects are the need of the hour. And for this to speak about is a internationally acclaimed, reputed speaker, Dr. Prasad, a dynamic person, a person who is very vastly knowledgeable. Even though he is in private sector, he is doing better academic work than many of us in medical college. He is one of the founding pillars of the Asha hospitals in Hyderabad, and I request Professor Rao to deliver his lecture. Thank you.
Thank you very much, Chairperson Venkateshan, for those kind words. Madam Selvamani, first of all, let me express my thanks to the IPS South Zone, especially Mohan Chandran, who actually said that over the last year I have been sermoning you. I don't think I was sermoning you, I was just taking your help, and I think Indian Psychiatric Society moved quite well, quite fast. Though our current president says that we are in crossroads, maybe so, but I think we have moved much faster than many other societies in this country. And I think we should move with an optimism, and I'm sure we are doing that. I was giving this topic of the newer antipsychotics in the horizon. To start with, I have no conflicts of interest to declare. The drugs in the pipeline for psychiatry in general, antipsychotics in particular, I would go back to Goodwin, our famous psychiatrist, who about 7 years back said, we are not going to get any more new drugs for the depression, or for that matter for any psychiatry, mainly because the costing has increased and the pharmaceutical research is not really productive. In fact, a lot of the big multinationals stopped investing, and the story is now emerging that it takes $1 billion to get one successful molecule. You can actually buy two A380 Airbuses with that money. But having said that, again as an optimistic, what has changed is, now previously one company used to have one molecule, and now in the modern times you find that, for example, Lurazdan has 4 parents. That means they own that. They spend money for that. So with that background, I think Venkateshan has talked about this. Consider this fascinating disorder of schizophrenia. The positive symptoms, antipsychotics are used. For cognitive deficits, some of the newer antipsychotics are putatively suggested that they would work. The negative symptoms, sadly, the molecules right now, in the truly negative symptoms, we don't seem to have an answer. For the disorganizations, antipsychotic drugs works. And for the mood symptoms, the antipsychotics works. Now, what has changed in the last decade? What is going to be in the next 2 years? That would be the focus of my lecture. And very positively, antipsychotic drugs have changed their class now the newer antipsychotic drugs are no longer just a dopaminergic drugs. In that way, yes, we have to choose an antipsychotics. When we choose our antipsychotics, again I might add as a rider, antipsychotic drugs are not used only for the symptom amelioration of schizophrenia, but they are also used for the bipolar mania as well. Not only them, I think the newer trend seems to be for psychotic depression, and for that matter lurazidone, it is used purely as an alone drug for a bipolar depression. So there seems to be a change, but when you choose an antipsychotic, what we want today, ideally everyone sitting here, we want that should not have a metabolic symptoms, should not have an EPS symptoms, should not have a cardiovascular problems, should not cause any hormonal, for example prolactin. So probably we are living in an utopian, we still don't have an ideal antipsychotic. What has happened to the new molecule which came last year? I think it came with a great hype, and most of you sitting here thought lurazidone is the answer for all our schizophrenia. That's what the pharma company did promote. I was always skeptical when we promote the evidence. We also know what happened. Strangely, but surely, it has evidence for bipolar depression, it has evidence for schizophrenia. The claimed efficacy when compared to, for example, olanzapine or risperidone, it doesn't seem to be as great in the positive symptoms, but surely my practical experience tells me we can use that molecule for certain category. For example, a person who is growing fat with olanzapine, you need to change track. It might not be a great antipsychotic, but it's still a better metabolic. So with that background, lurazidone, the experience seems to be question mark for most of you, and my experience collecting across the country, it seems that a majority of psychiatrists are not confident to start it as a standalone molecule. You need to gain an experience. Now the way I wish to cover this session, first I will tell you about the 2 or 3 molecules which are likely to come by the next 2 years. Then I would cover very briefly what are all the promise of molecules for the next 5 years. I'm going to tell you that the already existing molecules, whether we have a new drug delivery systems and what, and I would broadly categorize them as hybrids and other combinations. In a truly sense, in antipsychotic, we have 2 important molecules, and this premawasarin, this is a wonderful molecule, but with a very selective use only for Parkinson's disease hallucinations, and this is the only molecule approved by US FDA. So this is an approval for those suffering Parkinson's patients who are receiving the levodopa, carbidopa, and who over the period of time, some of them develop hallucinations. For them, US FDA has this. I will briefly tell about that. But if you really want to know what is going to happen for the next 2 years, these 2 molecules can come to our country. Cariprazine and brexpiprazole. About that, I would present a brief detail, and these 2 molecules are actually not a really new innovative, but they are atypical in the same sense, but with a little, again, as Stephen Stahl tells us, each molecule has a different setting of various neurotransmitters. Let us start with cariprazine. I already told you these 2 molecules has multiple parents. This is developed over the last 12 years. As I said, I was not part of the drug development, that's why I didn't have any interest. Though I was approved as an investigator for 2 trials, our government of India has blocked the trials. Having said that, ultimately after about 2,200 patients put on trial in a double-blind placebo, both for schizophrenia and bipolar, finally US FDA has approved on September 17th. And this is primarily owned by Forest Labs, but it also has multiple parents. Coming to the basic pharmacology, which most of you would like to know, it is naturally an antipsychotic, atypical antipsychotic. And the beauty of this molecule, if you may, and it is somewhat similar to aripiprazole, is it has a partial agonistic activity in the central dopamine 2. And I'll come to that briefly when we delve to know what is the beauty of this. And naturally it has a serotonin 5-2A antagonism. That is the antipsychotic action. And what does dopamine 2 do? Remember, our Kshitij Kapoor has said the deficit in schizophrenia is in pre-dopamine, and that's where this molecule probably acts as a dopamine. Naturally, with this data, cariprazine has about 2,500 patients now, and adding on another 1,000 patients, which the phase 3 trials have added, it is approved for schizophrenia, and it is also approved for acute mania, in bipolar mania, and also in mixed episodes. So that's what the story is. The pharmacokinetics is slightly difficult in only one sense. It has a very long half-life. In fact, if patient starts using it, the metabolites adds to the action, so it can last as long as 1 to 3 weeks. The dosage probably, that's why is much lesser. It's less than 1 to 3 milligrams. So that is the key thing, and metabolized by CYP3A4 pathway. So remember, all the drugs which have effect on this, we probably will have an impairment of the usage of this drug. So that's the only pharmacokinetics which you need to remember. So cariprazine selective D3 selectivity at a lower doses. Remember, again, we have some of these molecules like aripiprazole as well, like lurazidone as well, has somewhat selectivity. At a very low dose, it has D3 partial agonism. And remember, this is for the negative symptoms or the core symptoms of schizophrenia, and there seems to be some data which shows this. Let's not jump and say that this is going to be the drug for that, but right now the evidence do suggest one for the negative symptoms or the vegetative symptoms of schizophrenia. Also remember, when we write cariprazine, because of the long half-life, sometimes it is quite long, and if you compare this with the two other similar kinds of molecules, that is aripiprazole, which has 94 hours, and brexpiprazole also has 91 hours, this molecule has 1 to 3 weeks. So that is going to be one challenge. So parent compound along with this metabolites has a quite long, that's the take-home message of cariprazine. Regarding a core data, as I already said, from the baseline in most of these trials of about 97 on the PANSS, there is a reduction of 19 to 25 in a 6-week trial, which is quite a good thing. In fact, most of these 3 trials, study 1, study 2 and study 3, have taken acute relapse of schizophrenia. So that is the data right now. And similarly in bipolar 1, and again like lurazidone, it does seem to have action on the depression. So these are the 2 indications, and these are the trials. And as I already suggested, about more than 2,500 patients live, both double-blind placebo compared to placebo, we have this data. So cariprazine is going to be, and right now safety data is coming. For us to remember, only 2 important side effects, which are more than 5%, are akathisia occurring around 14% and EPS. So this is a drug which is going to cause EPS, so probably we need to use triacylphenidil. Similar data in bipolar depression, though in bipolar patients we had more of a dyspepsia and gastrointestinal symptoms. The reason might be is the higher dose was used in bipolar mania. Now, in summary, at US today, for a 1-month course varying between 1.5 to 6 milligrams per day would roughly cost more than $1,000. $1,200 per month is the cost right now in United States. Now, the good news for us is that some of these trials were done, and I think some of our companies have started. I do see that in 2018 this molecule can come to our country. Brexpiprazole, the next molecule. This again received the US FDA approval in 2015. Patent originally is from Otsuka, the same aripiprazole. See, they developed this molecule in the next generation of aripiprazole. Subsequently, 4 patent companies across the world, including Europea. And right now, this is probably one of the most commonly used molecule across the world, mainly because this has a multiple marketing both in Japan, in those countries, in the Oriental countries, and down in the Europe. The pharmacology is again, typically it's an atypical antipsychotic, not so dissimilar to cariprazine. In one way, it also has central dopamine agonistic action, again has antagonistic in 5-HT2A receptors, which is for the antipsychotic, but also has serotonin agonism for 5-HT2A1 receptors. So this is the core of pharmacology. So it has again been approved for both these indications. So incidentally, if you really see, lurasidone, cariprazine, brexpiprazole has all these same indications. Do you know why? Because from the marketing point of view, as they developed the molecule, they tried for these 2 indications so that they get a little larger. So that's where the data is. Coming to the pharmacology, as I already said, the partial agonism is one, again, atypical when compared to the previous atypicals. So this is likely to be beneficial in the negative symptoms as well. Having said all these things, we need to say how it's going to work, because the data is just emerging from the practice. It also has the agonism at the central dopamine and serotonin 1-HA. That also is a pro-cognitive area, and we need to see the benefits from that, but right now we don't really have data on that. So that's what the pharmacology is about, and as we go further, bioavailability, again metabolism, pharmacokinetics wise, it is similar to the cariprazine. So these 2 molecules seems to be growing in the same pattern in terms of metabolism as well. So we have to be careful with all the drugs which are either like the antifungal molecules and other molecules which are either inhibiting or who synthesize. Again, this molecule has a long half-life, 91 hours. And for those of you who want to know the data about it was initially tried in 2 different indications, one as an adjunctive treatment in MDD, wherever there is a treatment resistance, and in schizophrenia, and both we have positive studies, there are no negative studies, which means brexpiprazole has 2 good indications. One, MDD and bipolar depression. It is not yet approved, by the data is coming. So we still have the similar class of molecule going further. As we go further, in terms of safety, again, weight gain, not great, but in 6% of patients, there was 1 to 3 kilos weight gain in a 6-week trial. So this is again dissimilar to cariprazine. Cariprazine didn't have this. Akathisia again common. So there is the usual black box warning, like any drugs in this class. The starting dose is 0.5 milligrams. In depression, we should go to 1 milligram per day, and maximum dose recommended is 2 milligrams, whereas in antipsychotic we can go up to 4 milligrams. And side effects of EPS are much less with this molecule. So good news, at least at this point of time, these 2 molecules can come in the near, if not so near future, maybe in 1 to 2 years. That's my prediction. If you compare between both of them, they have quite a lot of similarity. As I already said, dopaminergic agonism, but also selective D3 receptor agonism a little bit. So in terms, they are slightly different from the available molecules at this point of time. And I just want to show you a comparison. For example, aripiprazole, which is the preconcener to this class, This has an approval for almost all varieties of schizophrenia, all varieties of bipolar disorder, including the children, Tourette disorder, etc. But at this point of time, I think brexpiprazole only has for schizophrenia and bipolar depression, and cariprazine has for schizophrenia. Brexpiprazole has for as an adjunctive for depression, whereas cariprazine has for bipolar depression. So this is what two molecules which we are likely to have. And the third molecule, which might not come so early because this is highly selective indication, first drug exclusively approved by US FDA for hallucinations in Parkinson's disease, Primavaserine. This had a few 6-week trials. It's a breakthrough therapy in a way. 199 patients have been tried, very small sample. Remember, these patients are also small, and US approval for the first time gave for a very large sample. So this is what, ladies and gentlemen, in terms of the molecules which are likely to come in the next 3 years. Now, what are the molecules in pipeline? Sadly, as I said, they are not quite many. And intracellular therapies, one molecule has actually crossed the border, which means it is in the verge of getting approval by the US FDA. The name is not yet given. Again, it's a selective 5-HT2A receptor agonist, essentially. And remember, it is an agonist. And this is a different class. And in the various trials, again has a very good differentiation with the placebo at this point of time. We are anticipating approval anytime in the next 6 months. And the launch is being prepared for the January of 2018. That's what, according to the data right now available. US FDA has, we have large data done. The second molecule is Lundbeck's molecule. Again, this is again atypical when compared to all the other molecules. Not yet named, you have a number for that. D1 agonist, again, serotonin 2A antagonist, and interestingly 5-HT6 agonist, again cognitive, pro-cognitive. This also crossed almost 964 adults have been already studied. There is a differentiation. The estimated completion is around March, the final phase 3 trials, and this is a molecule again seems to be great promise because it has crossed a lot of hurdles at this point of time. Again, from the side effects point of view, mild akathisia, mild EPS, nothing more, no metabolic side effects at this point of time, no prolactin at this point of time. Cognitive trials are also positive at this point of time, but as I said, a large multinational trials are going on, so this is a molecule which we can anticipate in 2018-19. Because it's a European molecule and Lundbeck has an Indian footprints, it can come to this. The third molecule is another intracellular therapies molecule, again slightly different from the previous one. This is also likely to be approved. And a final fourth molecule is from Minerva Neurosciences. It's called MIN-101. It's again first in class because this is the first time, as you can see here, sigma-2 receptor action it has. No other molecule has been approved in this class. This is likely because this also has come to phase 3 trials, which means proof of concept and definitely the first 2 double-blind trials. Again, this is anticipated launch is around late 2018 and 19. So these are the 3 to 4 molecules which we can anticipate in the next 2 years. And finally, this is not a new molecule, this is a new combination they're trying. Remember, olanzapine is still the best molecule, but it causes severe metabolic symptoms. So they are trying this combination of samidorphan, a mu opioid receptor antagonist, along with olanzapine to counter the metabolic symptoms. So this is a new combination. The trials are positive at some extent. One trial is definitely positive for weight control in a short term. Now they are observing for 6 months. We might get this much earlier than I anticipate, maybe around 2018 itself, because the data seems to be positive. And remember, this is an old molecule and we can get. There are few molecules, among them agmantine is one molecule. This has a quite a range of actions, including monohormone hypothesis. the neurotropic hypothesis, glutamate hypothesis. So this is a kind of a mixed bag at this point of time. I'm not sure where it's going to lead, but this is one molecule. Now I'll come briefly to the last part of my presentation, the two important innovations which all pharma companies are trying to see whether we can deliver the drug for a longer time, whether we can deliver in a better mode. Among this class, as you know, all the molecules right now currently are there. They are being tried as a nasal, sublingual, all this, they are at various stages of development, and probably this would come much earlier, and some of this research is, ladies and gentlemen, is happening in this country as well. One of the interesting things which is happening is with the risperidone. We are probably going to get much faster in the next year, before the next year is risperidone monthly injections. And this is 2 injections we need to combine. And what they have tried is, there are 2, that is risperidone as a powder form, and also we add the chelating kind of a thing, which contains it's called Atrigel. It's a delivery system just before giving injection and give to the patient. But more interesting to me, though sometimes it is little dangerous, they are now trying on a 6 months subcutaneous depot, and that's going to get, and probably that is the interesting part apart from the risperidone monthly, an implantable 6-month formulation of risperidone. That's quite advanced. Remember, this is a old molecule, but the delivery system they have changed. And I would like to acknowledge that I didn't cover the other ones. They are all multiple bits and pieces. As I said, only 4 molecules are there in the real pipeline. Targets of mRNA, psychobiotics, chynurenic acid metabolism pathway drugs, they are all at the phase 1 trials, and some herbals, including some from our country, but I didn't cover in this. But the take-home message, somewhat optimism and somewhat pessimism, is we do have 2 molecules likely to come in the next 2 years, but nothing great sensational to happen. But what is going to happen is, these 3 molecules, if they come, they add to our 10 to 15 molecules which we commonly use. Probably there are some selective patients which need this. Thank you, ladies and gentlemen, for the patient listening.
Good afternoon, everybody. Being a pioneer in psychopharmacology, Dr. Mohan Prasad has presented very well about the newer molecules. He is excellently presented with his experience and evidence. I don't think I cannot add much more apart from this. Thank you very much.
As said by the co-chairman, Prasad Rao has given a lucid and excellent exposition of the various drugs, which are newer drugs which are approved and which are on the pipeline, and the newer drug delivery models, drugs that are going to develop. The floor is, the topic is open for discussion. Any queries, you will be prepared to answer it. Thank you.
Many drugs, after olanzapine, no drug has stood the trial of practice. Asarpine came, went. Then lorazepam again. I don't think it has picked up as we have expected. Then zotipine came, that also went. So what is going to be because there is a pharmacogenetic issue is there. Maybe international standards, international community, it may have responded. They are too particular about side effects than effects. Our people, Indian populations, tolerate better, and economically, and I think viability is a problem.
No, I would answer this. I would preface it. See, whenever a new drug has come, see, very, very sadly, over the last 7 years, we had only 3 molecules, and lorazepam came after a long gap. In fact, lorazepam has to be used very delicately. Start with a small dose. Ideally, start with 20 milligrams, wait for a week, slowly increase to 40 milligrams. The difficult period is usually first 2 weeks. Lurazone is still a good molecule if you use it properly. For an antidepressant dose, it is only 40 milligrams you need to go. Don't go beyond 40 milligrams. You can go up to 60 milligrams. Even in the clinical trials, that is the data. For the antipsychotic also, as I said, start slow, go slowly over the next 3 weeks, but go up to 80 to 120 milligrams. There are some patients who respond. The problem I found, and across the country that's true, that most of the patients who are put on lurazone were treatment resistant. Don't do that. Start with a very fresh patient, then gain an experience. Now, I wouldn't agree that we are sad. See, each of our schizophrenia patients are different because phenotypically schizophrenia is not a single disorder anyway. There is a different. But what we get, and both brexpiprazole and cariprazine are different. They are likely to be beneficial for negative symptoms. That's the good news. This kind of promise also we have with aripiprazole. If you carefully use aripiprazole, it is some negative patients at a lower dose they are going to benefit because the partial agonism works for them. Now, this cariprazine and brexpiprazole do have a little promise in some syndromes and some symptoms. But the other three, especially the Lundbeck molecule, seems to carry the promise which is likely to come. Let us also remember, we are not looking for a magic pill. I agree that olanzapine is the best molecule for most of us because it doesn't have EPS, but it has a metabolic component anyways. So theoretically at this point of time we don't have an ideal antipsychotic. But each of our patient is different, and there are some patients who respond to pimozide. You need to choose and select, and that is the art of psychopharmacology which each one of us will develop over the time.
Sir, I'm Dr. Nirmal, practicing psychiatrist at Trichy and teacher at Perambalur. One common problem me and my colleagues face is with long-acting antipsychotics, including the newer ones like olanzapine. It works wonders for some patients and all, but most of them don't take up the anticholinergics we give also, because we choose patients long-acting when they're not compliant. So many of them land up with severe extrapyramidal symptoms, even with long-acting olanzapine. So I just wanted to know, is there some preparations of anti-Parkinsonism drugs which can be given as a long-acting form, either orally or injection?
If you would have seen that in that list, there is that they are preparing a drug delivery even for triaxiphenidil. You shift them to Invega, they are likely to have less EPS. But with Invega and risperidone, prolactin is an issue. Logically, that's where you have to watch. But each molecule, olanzapine, as you said, see, you cannot start any long-acting without stabilizing. So once you stabilize, the weight gain is not that much, though metabolic you need to monitor. So each of our molecule we need to work, and as we develop a control on each of the molecule, probably that's where your art of psychopharmacology comes.
I have certain questions, sir. Excuse me. One thing is, your comments, especially what we read is Cutlass and Cutty studies. They say the long-term side effect follow. Older antipsychotics and newer antipsychotics, there is not much of a difference. But what we see today is, compared to 20 years back, after the advent of antipsychotics, definitely we are seeing less of extrapyramidal side effects and tardive. That is but I am not disputing the study. Why is this different? Other thing is, when we use subcutaneous depot, when we were student days, there is a fancy to give disulfiram pellets, which last for a long time, and patients who are not, but it leads to so much of dangerous other side effects. So we should be a little more cautious in using these cutaneous pellets. That is one thing. Other thing is, when we in our setup, we always have to think of the pharmacoeconomics. Now our older antipsychotics and newer antipsychotics are almost similar. So that also we have to keep in mind while using the drugs. Thank you.
No, I agree with all your three comments. Especially what's happened is the Cutlass and KT has given limited insights on some aspects of schizophrenia, not all the answers. For example, the molecules chose in the KT study, the amount of dropouts at various stages and going to various classes. But they did give insights. Likewise, cut class is only for the pharmacoeconomic part, which gave a little limited data. But I think subsequently, right now, the networking of the schizophrenia, both in the German groups and in the European groups, is giving much more data. I personally think our experience with a molecule is the one which operates in what our prescribing pattern. And that most of us sitting here, the seniors, know. The youngsters should learn, hold a control on the molecule as you start prescribing, be with the patient for few weeks to few months. That is the more experience than these studies. And finally, I think what is changing, if at all, and pharmacoeconomics point, the newer molecules in this country which are likely to come, cariprazine and brexpiprazole, are still not on the GATT control. So we'll get a lower rate only. Whenever it comes, it's not going to be as costly as before. Flurazidone is a bit more costly than olanzapine, but otherwise risperidone is the cheapest, I think cheapest antipsychotic available. So we need to go with the pharmacoeconomics, especially when 80% of our patients buy their molecules.
One question.
Yeah.
Do you find any ray of hope of drugs acting on the glutamate? I don't know if you got metabolism, which combined with the dopamine receptors could be a better option in future. Is there any personal intuitions?
You have put the answer there itself. The ray of hope. See, as GSK, then Pfizer, Lundbeck, Eli Lilly burned their hands, almost spending $500 million on this glutamatergic pathway over the last decade. None of the molecules crossed the experimental animal stage to the hypothesis is very interesting. For us, it's tempting. But from the molecular development, psychopharmacology-wise, it is a real failure. There is still one molecule in the pipeline right now crossing these phase 2. There is the ray of hope in that molecule if it works in the other level.
Any more questions? If there is no questions, we will close the session. Once again, thank the presenter,
Thank you.
Dr. Rao, for his good presentation. Thank you.